Well, hello, everyone, and welcome to today's Future Direction of Lab Medicine webinar on real-time quaking-induced conversion assays from prion disease to emerging neurodegenerative diagnostics. I'm Dr. Linda Hasadsri, an assistant professor of laboratory medicine and pathology, as well as the director of the Molecular Technologies Laboratory in the Division of Laboratory Genetics and Genomics at Mayo Clinic, and I'll be your host for today's webinar. And as your host, I am delighted to introduce our speaker today, Dr. John Mills. Dr. Mills is an assistant professor of laboratory medicine and pathology, as well as co-director of the Neuroimmunology Laboratory in the Division of Clinical Biochemistry, also at Mayo Clinic. And with that, I will now turn things over to Dr. Mills.
Thank you, Linda, for the introduction. Thank you all for joining this morning. So today I'm going to be speaking about RT-QuIC assays, particularly in their role in the diagnosis of prion disease, but we'll spend a little bit more time at the end talking about other potential applications. So for some learning objectives today, I've listed 4 here. Understand where RT-QuIC fits in the diagnostic workup, describe the biological principle of RT-QuIC assays, summarize their diagnostic accuracy and sources of variability in their performance. And then we'll spend a little bit of time talking about risk associated with handling prion CSF and blood samples. So we're going to start off just an overview on dementia. So there's approximately 500,000 new diagnoses made per year in the US. Majority of those are Alzheimer's, and then incrementally smaller amounts related to vascular dementia, Lewy body dementia, frontotemporal dementia. And then a subclass of dementias, the rapidly progressive dementias, actually make up less than 5% of all dementias. So the rapidly progressive forms are actually caused by a heterogeneous group of underlying etiologies. The definition of a rapidly progressive dementia vary according to the cause and relate to the speed of cognitive decline, the time from first symptom onset to a dementia syndrome and or overall survival. A general definition is symptom onset to severe dementia in less than 2 years. So that's the definition that we're going to work off for rapidly progressive dementias for today. So this is a study that just highlights the underlying etiologies of rapidly progressive dementia. Kind of think of them as those that are neurodegenerative and those that are non-neurodegenerative. I won't go through all of these, but your neurodegenerative diseases are Alzheimer's, CJD, Parkinson's, frontotemporal dementia, and then your non-neurodegenerative are your more, I would say, less targeted destruction of the brain, so autoimmune encephalitis, tumors, metabolic toxicity, etc. So recognizing the cause of these diseases is critically important. Again, these rapidly progressive dementias progress very quickly. And when you look at the different etiologies, you can break it down into those that are readily treatable and those that are not. So that blue circle kind of indicates those that we would consider relatively treatable or easy to treat. And then the others are those that can be tricky to treat, or they're, in the case of CJD, for instance, there is no treatment. So distinguishing these very quickly is important so you can make sure that the patient gets the right treatment as quickly as possible. The longer these diseases progress without treating these treatable diseases, the more irreversible the damage is. So very important to reach a rapid diagnosis in these patients. So the focus of this talk is really on human prion diseases. So these are a subset of the rapidly progressive dementias. They are fatal, rapidly progressive. They occur in humans and other mammals. On average, symptom onset to death for human prion disease is usually between 4 to 6 months. That can vary depending on the molecular subtype. The incidence is about 1 to 2 new cases per million persons per year. There are no currently available treatments that have demonstrated demonstrated ability to modify the disease course. So these, unfortunately, are considered untreatable, lethal conditions. Diagnosis of human prion diseases is particularly challenging early in the disease course, and that mainly is because of the heterogeneous symptoms and the fact that these symptoms overlap with diseases that have a higher prevalence in this population. So it can be very tricky, particularly early, to distinguish what is prion disease versus what is some other neurodegenerative disease or a non-neurodegenerative disease. So for this talk, I'm gonna try to simplify the language I'm using so you'll see me talk a little bit about human prion disease as well as Creutzfeldt-Jakob disease. For my talk, we're just gonna assume that those are equivalent. I'll get into a little more details about that. So the prevalence of prion disease varies pretty significant depending on the clinical setting. Because these are rare, so when you think about a primary care or community setting, the likelihood of a patient presenting at a primary care community clinical with prion disease is exceptionally low, less than 0.1% of cases. When you talk about a general neurology consult or secondary practice, this is slightly higher, but these are still relatively rare, maybe 1 per 1,000 dementia consults that may present, mainly because, again, there's much more common presentations that kind of fit this rapidly progressing dementia or dementia in general. And then in your tertiary referral centers or clinics that have rapidly progressive dementia specialty clinics, there it can be much higher, where prion disease actually may make up 15% of those patients presenting to these tertiary clinics with a rapidly progressing dementia. It's actually maybe even higher in certain specialty centers in the US. So I mentioned earlier that the diagnosis is critical early so that you can get the right treatment. But unfortunately, as I mentioned before, because of the overlapping phenotypes, there are several reports that have talked about the misdiagnoses of either patients with prion disease thinking they don't have prion disease, or patients with prion disease that actually end up, or thought to have prion disease, that actually end up having one of these disease mimics that are actually treatable. So I referenced 2 studies. Our lab one of the primary focuses of our lab is autoimmune encephalitis. And so this is particularly important to us, that recognition that there is a degree of overlap between these conditions, how they present, subacute onset. And so it's not that surprising that when people looked at patients with suspected CJD, actually about 7% had an actual autoimmune encephalitis at autopsy. And of those, a third actually had a detectable neural antibody. So again, these studies just highlight the importance of getting the diagnosis correct. The inverse, Flanagan et al. Demonstrated that there was 107 patients misdiagnosed, thinking they had autoimmune encephalitis, and then later subsequently were confirmed at autopsy to actually have had CJD. So there is, I think we do a good job of distinguishing these, particularly late in the disease course, but there is misdiagnosis that happens, and these are very problematic. Again, I mentioned before whether or not to treat, what to treat with, and then obviously those delays are very costly for the patient, but as well as for the healthcare system. So very important to get the diagnosis right as quickly as possible. So I'm going to talk a little more specific about prion proteins or prion-like proteins. So prion proteins are infectious protein particles, so they're proteinaceous. And then there's a subcategory we'll talk at the end of the talk that are prion-like proteins, so alpha-synuclein, tau. In general, these are self-replicating protein aggregates that are the primary causative factor in neurodegenerative diseases in mammals. And we'll talk a little bit more about what self-replicating protein is, how that works. But first, just these all kind of fall within a category of transmissible spongiform encephalopathies. So I mentioned earlier, these impact humans as well as animal. And the spongiform is basically at autopsy, when pathologists look at the brain tissue, what they can find is these spongy-like lesions, which are largely driven by massive apoptosis and killing of neurons that happens in the brain tissue of these patients. I want to spend a little time just going over the history of human prion disease. So it was actually described in the 1920s by Creutzfeldt-Jakob independently. And then in the 50s, Kuru was identified. So that is basically a ritual cannibalism in a group of people kind of in the Papua New Guinea region, where their ritual was to consume the brain of deceased relatives, mainly thinking that that was a way to keep that person with you, take their knowledge, etc. And so when this was first identified, it was originally thought to be a novel virus that was causing the disease. And for many years, people investigated, what was the cause of this, thinking, originally thinking it's a virus. But there were several key studies that basically ruled out that this could be actually viral in origin, basically by inactivating or destroying the DNA. They could show that they could take extracts that lacked any sort of viable viral particles and show that they could still transmit the disease in animal models. And it wasn't until Stanley Prusiner reported a paper in 1982, basically determining that it was a novel protein that was causing these infections, which at the time was, the first time anyone had just really described an actual infective particle that was purely a protein. He went on to win a Nobel Prize for this work in 1997. And eventually, his paper in 1982 was still met with a lot of skepticism about this protein-only hypothesis. And it really took over a decade before people really accepted these findings. But at this point, we know this to be the truth. So the pathogenesis of this protein, so the way that this works is all humans and animals express normal prion protein, which is expressed by the PR and P gene. So this has a normal essential role in healthy individuals, but occasionally through not so clear mechanisms, this protein can obtain a misfolded form. This misfolded form has the ability to aggregate normally formed protein and actually trigger conversion to this misfolded form. And this can undergo cycles and almost becomes exponential in the brain. These misfolded proteins generate large fibrils, which are destructive to the neurons and thus trigger the spongiform-like appearance on histology. The misfolded form is called the scrapie protein, or PRPSC, which is the pathogenic component of this disease. So the interesting thing about the prion is in its healthy and its normal biologically active form, it's predominated by alpha helices. So it has about 40% of its secondary structure is actually alpha helix. However, in the scrapie form, the disease form, what happens is this protein gets converted to a predominantly beta sheet form. And these beta sheets can basically, they have a propensity to stack with other proteins, forming these large fibrils that are destructive to the neuron. So it's an inherent property of this protein that it can undergo this transformation. And there has been a lot of studies to understand what the triggers are, and I can't say with certainty that we fully understand what causes the trigger, but we know that it randomly happens in individuals, healthy individuals, at a very low frequency. There are genetic forms of the protein that accelerate that, but in sporadic CJD, which is where there is not an underlying genetic cause, we don't fully understand what triggers that initial conversion. So that scrapey form of protein, there's actually, the prion protein actually has a couple different critical polymorphisms, and depending on what polymorphism is present, there's varying degrees of, there's some differences in how, depending on the molecular subtype of the protein, the patients may present with a unique presentation. Not only that, the prion protein is glycosylated, so there's different glycoforms. So in general, based on those polymorphisms, as well as whether or not the protein is glycosylated, there's 6 different subtypes, and these present clinically in unique ways. I will say also that some of these forms have a lower sensitivity for being picked up with RT-QuIC assays, particularly the VV2 and VV1 or VV2. Again, the 1-2 refers to the glycosylation pattern. The M and V refer to methionine and valine at position 129 in the protein. So there's additionally other kind of CJD etiology. So sporadic is again, the form that I was just mentioning, that makes up 85 to 90% of cases. And then there's also familial or genetic forms of CJD with commonly occurring mutations. These mutations are thought they accelerate the propensity of the protein to undergo that conversion to the beta sheet predominant form. These are autosomal dominant. And then there has been cases of transmission of CJD due to exposure to medical equipment, contaminated medical equipment, or receiving tissue-based products like grafts, hormones, brain injections, etc. Those are exceptionally rare, but they have been reported. And then variant CJD is basically mad cow disease that currently in the US, there hasn't been any detected cases in many, many years. But if you remember the mad cow scare, it was due to the cattle, mainly in the UK, that were carrier or had CJD, and then consumption of this meat or tissue was able to transmit disease into humans. Again, there's been a dramatic decline in cases, but we continue to surveil this in the general population. So those are your 4 main forms. So there's some diagnostic criteria for CJD, mainly focus on the CDC criteria. I've listed the European criteria as well. But a definitive diagnosis requires autopsy. And so what I'm showing here is diagnostic criteria for probable prion disease. And so this was updated in 2018 to include a neuropsychiatric disorder plus RT-QuIC. The diagnostic criteria prior to 2018 did not include RT-QuIC, and it was based purely on clinical presentations. You don't necessarily need RT-QuIC to reach probable prion disease if you have a clinical presentation consistent with the disease. So that includes rapidly progressive cognitive impairment, myoclonus, visual or cerebellar disturbances, pyramidal or extrapyramidal signs, and or akinetic mutism. So the diagnosis can be met clinically or simply a positive RT-QuIC with basically a clinical presentation that is consistent with CJD. So over time, the evolution of diagnostic testing for human prion disease or CJD has evolved quite a bit. So if you go back to the 70s, it started with brain biopsy, then they came out with EEG. Then there was some CSF studies where they had non-specific biomarkers that could be used to look at overall neuronal destruction. not necessarily specific to CJD, but more indicator that there was a rapid destruction of brain tissue. And then 2000s MRI came along and is subsequently evolved and is actually a critical component to working up these patients. And then kind of the early 2010s, the first RT-QuIC assays were developed and reported that demonstrated direct detection of the causative agent in CSF samples in patients with CJD. And then I would say 2020 onward, there's been a big push to look at the potential utility of blood-based biomarkers for this disease. I can stay at the current state that CSF is still the gold standard sample for assessment of detection of CJD, and that's mainly driven by RT-QuIC. We'll talk more about that. So in the diagnostic workup of any patient with a rapidly progressive dementia, there's kind of three critical parts: the clinical presentation, which is critical, understanding the evolution of symptoms, the timeline for symptom onset, the extent of deterioration over time. Those are critical. Along with imaging, I think MRI is probably the most important at this point. So there are specific MRI features that are highly sensitive and specific for prion disease. And then laboratory studies, so your basic labs, looking for infection, ruling out inflammatory markers, other potential causes. Autoimmune neural antibodies is a big one. And then some of the blood-based biomarkers for neurodegenerative diseases like A-beta and tau for Alzheimer's disease. In CSF, we look for, again, inflammatory markers, antibodies, infection, and then general and specific biomarkers. In rare cases, a biopsy will be performed in a situation would be a patient that's rapidly deteriorating, where maybe they don't have biomarker results yet, and they have suspicion that maybe it's a CNS neoplasia. So in these cases, they may actually do a biopsy. I would say that's rare, but that still is an important component to the diagnostic workup in some situations. When we talk about ruling out prion disease itself, so there's really only a single disease-specific test for prion disease, and that again is the RT-QuIC assay in CSF, looking for the scrapey form of the prion protein containing basically what we call that seeding capacity. We'll talk more about that in a little bit. And then historically, there's been use of what we call the non-specific biomarker test for neurodegenerative diseases. So I've listed these here. In the case of prion disease, the important ones are 14-3-3 tau, and then there's also now phosphorylated versions of tau that have a utility. These again are not specific, but they are they do play an important part of the diagnostic workup in terms of demonstrating, that indeed there is rapid destruction of brain tissue. So this figure is just a high-level overview of performance in terms of clinical sensitivity and specificity of some of these different tests and different studies that have looked at this. What I would like you to appreciate from this figure is that the 14-3-3 and tau assays, they do okay. I think the most important things to point out is that they do okay, but they still are not particularly specific, which is not unexpected. And sensitivity generally is in somewhere between, let's say, 80 to 90%. More recently, I would say 2015 onwards, there's been various groups that have looked at, instead of just looking at tau, looking at the tau to p-tau ratio to see if that has a better discriminatory performance. And studies that have been reported on relatively large patient cohorts have demonstrated that the tau p-tau ratio actually has a very good diagnostic performance. It's not The specificity is not perfect, depending on the study. I think, anywhere from 90 up to 98%, but pretty good sensitivity in that 90% range. And then lastly, RT-QuIC assays, which is the focus of our talk. Again, these really emerged only in clinically, let's say they really only emerged in the middle of the maybe 2014, 2015 time period. But these have been demonstrated to have extremely high specificity and very good sensitivity. And so I think everybody at this point in the field appreciates that RT-QuIC has of all the tests available, has the highest diagnostic performance of any test really available to identify prion disease, particularly in the situation where there's concern for a disease mimic. So I'm not going to go too much detail other than to say MRI has evolved. It's a critical part of the workup. Depending on the study, it's been reported to have high sensitivity in kind of the low 90s and very good specificity as well. I wouldn't say perfect, but high 90s. And this really should be viewed as a complement along with CSF RT-QuIC testing and neuropathological assessment in the diagnosis of these patients. So you've heard, I've talked a lot about the RT-QuIC assay, so I want to just go through the basic components of the test. So the way it works is you take a patient's CSF, you mix in some buffers along with a detergent, thioflavin T, which is a molecule that fluoresces at a unique wavelength when it intercalates into beta sheets. Along with, you include in this is recombinant prion protein. So this would be prion protein that is produced recombinantly but has kind of the native structure. And then you mix the patient sample along with the protein in this buffer, and you put it into a 96-well plate. And then this goes into a unique, this plate then goes into a unique instrument that basically can shake very quickly at specific elevated temperatures, so 42 degrees, 50 degrees, etc. And so what was reported by Claudio Soto originally, this type of format, and then several groups have repeated those results and refined this assay over time. But what was reported is if you cycle through a period of shaking, rest over time, what you could do is in vitro trigger a similar reaction that happens in biologically in a patient with this disease, which is any misfolded protein present in the CSF can convert the recombinant protein substrate that you put into the assay, can convert it into the misfolded form, and then undergo a cyclical exponential reaction. And so what this actually looks like, what the plate reader does is at incremental time periods, say every 45 minutes, it takes a fluorescent measurement. And if you get amplification of these fibrils, what happens is you get increasing amount of the thioflavin T that intercalates, so you increase your signal over time. And generally that happens kind of in an exponential format. And then over time, you'll get degradation of the signal. So you can kind of appreciate what a positive result looks like there in the figure versus negative. Negative patient sample, you won't see any reaction. Positive, you'll see this kind of exponential increase and then a gradual decline in the signal. So originally in 2001 is kind of an original concept of how this assay would work. And that actually was utilized sonication, included some enzymatic digestion. And then in 2011, what we call first generation RT-QuIC assays, they used a particular type of substrate. And at that time, they demonstrated very good sensitivity, somewhere between 60 and 90% and high specificity. And then in 2015, a second generation of this assay was developed that used a truncated form of a recombinant hamster prion protein. And that actually is the current generation that we use in our laboratory and most laboratories use that are testing clinically. And that basically achieved an increase in sensitivity and maintained high specificity. And so the figure on the right is a composite of studies assessing diagnostic performance in first generation versus second generation. And so what you can see is an incremental increase in sensitivity and maintaining very high specificity. So just a little bit about the assay we perform at Mayo Clinic. So as most laboratories that perform this assay, from my understanding, produce the recombinant substrate in-house. This is kind of the overall workflow. And I only mention this because, as we'll talk about later, the quality of the recombinant protein is the critical aspect of the assay. So great care goes into producing this protein substrate, ensuring consistency, ensuring minimal differences from batch to batch. It's really the critical component in RT-QuIC assays. So the way that we set up this assay at Mayo Clinic, we do it in a 96-well plate format. We include 2 positive controls, 2 negative controls. Every patient sample and control is tested in 4 different wells per patient. Just high level. We'll get into why 4 wells in a little bit, but just zooming in on what the results that you get from this assay look like. So there's a few components. So the red curve here indicates a positive result. So from the time the reaction starts to where we first see evidence of amplification, we call that the lag time. And then once the amplification happens, it generally happens very quickly, and you get this exponential quick growth. And that peaks, and then over time, there's a decay period. And so in our lab, what we do is we go out to 30 hours. So we let this reaction occur for 30 hours. And we look for evidence of an exponential reaction to happen within those 30 hours. People have looked, is there correlation with the amount of lag time and certain clinical features, the amplitude of the signal and certain clinical features. And there's some correlation, but it's not so strong where we can make robust clinical conclusions based on what we see with RT-QuIC. And so really what we're doing is it's a qualitative interpretation. Do we see amplification, yes or no? We test each patient in 4 wells. So then the question is, in those 4 wells, how many of those wells reacted? The reactions are generally binomial and by nature. So imagine you're sampling out of your CSF sample, you're putting 20 microliters of CSF into each well, and then you're basically saying, if I have a lot of seeds in my sample, there's a certain probability that I'm going to get a reaction in any given well. And if you actually dilute out the seeds, it actually closely follows kind of binomial distributions. And so the way we interpret these is basically a negative patient seen on the left here. You would basically see no reactivity, kind of a flat line. A positive case, in this case, is 3 out of 4, right? So we can see 3 out of the 4 wells demonstrated amplification. And then pretty much everything that we see in the lab falls somewhere between negative and 4 out of 4, and they look typical, as you can see in the positive. Occasionally, though, we can see the presence of interference. So the third column here is an instance of where we saw amplification, but as you can appreciate, those curves look very atypical relative to the positive sample to the left. And so in this particular case, we suspected it was a false positive. We didn't call it positive. We got clinical information, and indeed the patient did not have prion disease, but unfortunately, we were never able to identify what triggered this kind of atypical reaction. So when we interpret these results, not only are we looking at was there reactivity, but we're also looking at the shapes of the curve, ensuring that they're consistent, et cetera. The last example is a serum sample. So occasionally somebody will send in, for whatever reason, perhaps a clerical error along the testing process, they'll send in a serum. And so if a serum were to get on the assay, it actually looks quite unique from CSF. So the far left is a negative CSF, far right is a serum sample. So you can see kind of the background signals elevated. There's this pretty extensive drop in the very beginning of the reaction, probably due to some quenching that occurs with the thioflavin T. So again, the Mayo assay, we tested 4 replicate wells. Any sample that shows a positive signal in one well, we would repeat for confirmation. And then based on the number of positive wells on repeat testing, we'll issue a positive or a negative qualitative result. Occasionally we have our reporting rules, which if we detect a sample that goes, say, the first time it was 4 out of 4, so it shows strong reactivity, and the next time we tested it, it shows 0 out of 4. Based on binomial distribution, the likelihood of that happening is exceptionally rare. So in those instances, we would report or repeat a third time to figure out what was going on. So we have these extensive reporting rules to ensure that the results that go out are accurate, and we try to minimize any potential for error along the testing process. So when we launched our test in 2024, and prior to doing that, we actually compared, this is just a study where we kind of did a blinded assessment comparing our assay to, at the time, the only laboratory in the US offering this testing. That was the National Prion Surveillance Center. Just high level, we get very good agreement with them. In this particular study, we were able to pick up 2 cases that were called negative at the National Prion Center. And then interestingly, both of those cases were cases that are subtypes of CJD that are known to be very difficult to pick up with RT-QuIC. And I only mention this because it is important to understand that no matter where you test, there's always the possibility that any given assay can miss a true positive case. And so in cases of a negative RT-QuIC result where there is very, very high remaining suspicion, we would always recommend either we repeat testing in the lab that we have the sample to rule out sort of a lab error. We would also potentially suggest repeating the testing if it's clinically warranted by sending in a new sample, or even if it's tested at Mayo, consider sending out a sample to the National Prion Center. The reason is that this is I mentioned before, the recombinant protein is very critical. And so there's always a concern that the test doesn't have perfect sensitivity nor perfect specificity. So given the importance of a diagnosis, if there ever is any question, we definitely recommend additional testing, and we will work with the clinician to coordinate to make sure that we get the appropriate result. So just high level, there's a few variables that impact assay performance. I mentioned before the molecular subtypes. So we know like VV2, MV1, or MV2 are very difficult to detect by RT-QuIC. Where I mentioned the overall sensitivity is somewhere in 93 to 95%. For some of these subtypes, it actually can drop down into the 60% range. The other factor is disease burden. So very early on in the disease course, it is more difficult to detect RT-QuIC positivity, just because if there's less seeds circulating in the CSF, it's harder to pick it up. So depending on the stage of the patient, if they're very early in their disease course and they continue to progress, that's a situation that if you had an initial result that was negative and the patient continues to decline, a subsequent test, if clinically warranted, would be indicated. The other thing is the presence of interfering substances, and I'm going to talk a little bit about blood contamination here shortly. But different labs may have different criteria for how they detect an interfering substance and or how sensitive their assay is to an interfering substance. And then lastly is the protein substrate quality is critically important. In summary, though, I would like to say that we have very high concordance with the National Prion Center in all the studies we've done. There was a ring trial that was a multi-center study where they sent it out blinded positive and negative human prion disease CSF samples, and across all these labs, they demonstrated very high concordance. So the take home here is that RT-QuIC assays are very robust. The labs that do offer them for almost the vast majority of cases generate equivalent results. But there are rare instances where one assay may pick up a case and the other assay will miss it. And I can assure you that although we have picked up cases our National Prion Center has called negative, there have also been an instance that I'm aware of, at least, where we missed something that they picked up. So keep that in mind when you're, if you're an end user of this test, you get a negative result, there's still doubt. If it is clinically warranted, repeat testing always makes sense. RT-QuIC specificity is very high. It's not perfect. There have been reports of negative RT-QuIC positives in non-CJD cases. There are interfering substances, lab errors potentially. I do want to mention adjunct non-specific biomarkers can help identify those errors. If you get a strongly positive RT-QuIC and a negative biomarker or vice versa, that may indicate to you, okay, you need to repeat the testing because something doesn't make sense here. Blood contamination is a big one. Bloody taps are common, so anywhere from 5 to 15% of CSF collections have blood. It's long been appreciated that blood in the presence of CSF is an inhibitory to RT-QuIC assays. So what we do in our lab is we actually did a study where we diluted different amounts of blood serum into the sample to kind of define limits where we start to see inhibition of our RT-QuIC assays. I'm going to go a little quick here. So basically, we took whole blood, purified intact blood cells, lysed blood cells, diluted known amounts into samples, and then tested with positive patient samples to determine at what point do we see an interference. And so for us, we actually measure the heme in the CSF sample at 414 nanometers, and we have a threshold of 0.078. So any sample greater than that, if we call that our blood contamination assay. If the sample has a OD above that limit and it's negative, we actually report we detected blood. We don't issue a result because we say that could be due to a false positive. If the sample is positive in the presence of blood, we would report like normally. Because blood is a negative interference, it does not generate false positive results. So about 5% of the samples that come to us have blood above our tolerance limits. Quickly, so some of those non-specific neurodegenerative biomarkers. So I mentioned before 1433 tau. This is a study we did with 383 residual samples, just demonstrating, this isn't new knowledge, but just demonstrating that RT-QuIC certainly outperforms those non-specific biomarkers. We get very high sensitivity and specificity. We do an adjunct in our panel. We do an adjunct test that is total tau to p-tau. I mentioned earlier there are studies showing that this does generate very high sensitivity and specificity. So we performed an internal study. This is kind of highlighted here. Based on our study, we set a ratio, tau to p-tau ratio of 18 as being abnormal, and a total tau greater than 383 micrograms ml as a positive result, indicating this would be consistent with prion disease, not specific for, but consistent with. And this is just how this test performs across various disease mimics. So in general, we get very high with the total tau p-tau ratio. We get very high sensitivity. I can say it isn't perfect. So sensitivity compared to RT-QuIC here, not sensitivity for the disease. Specificity is lower. In practice, I think it's even a little lower than this. This particular study just demonstrates that very good sensitivity, specificity that's better than 1433. So we move forward using a total tau p-tau ratio in our panels rather than 1433 or tau alone. So we offer two panels, an RPD panel, which is just RT-QuIC, and then the tau, total tau and the tau ratio. This is recommended in cases with very high suspicion of CJD. And then because can be rapid onset Alzheimer's disease that can mimic prion disease, we also have a kind of a combined panel that includes the AD markers along with RT-QuIC. This panel is more appropriate in the context of some suspicion, but certainly some overlapping clinical features that makes the clinician pause about, is this prion or is this some other maybe neurodegenerative disease? So our experience offering this test since 2004, this is just an early snapshot of the first 300 cases we tested, but this has continued over time. Our positivity rates are somewhere between 10 and 20%. So in our Mayo patients, it's about 15%, a little higher for non-Mayo patients. This really is just highlighting that the test is being utilized properly. And it is, as far as we can tell, all positive patients, all Mayo patients that we chart reviewed so far have had disease. We have not yet identified any where we've, except for, one case where RT-QuIC was negative, and the patient had CJD, and that was again one of those rare molecular subtypes. This is just a study looking at post-validation in clinical practice. How does the tau ratio compare to RT-QuIC? And what I can say is that it has done very good sensitivity-wise at picking up RT-QuIC positives. I would say, looking at the breadth of all the testing we've done, we have only had a couple cases where we missed on the tau ratio. But it is not specific. It's somewhere 80 to 90% specificity in clinical practice. It does outperform tau. So again, this just justifies why we utilize the ratio as an important kind of adjunct method along with RT-QuIC. I'm going to skip over this. So the reason that we're doing this at Mayo is, one, try to increase accessibility, make this available at more than one place, try to get results out quickly. Initially, the goal was the Mayo Clinic practice. How can we ensure that we can get them RT-QuIC results quickly? And then, because of the overlapping disease mimics, we already do a lot of the testing here at Mayo, so it also made sense to include this testing as one of the components to our test menu. And we felt that we had an opportunity to really improve turnaround time and then provide a high-performing test. So I did want to spend the last couple minutes here just talking about the National Prion and Pathology Surveillance Center. So they were founded in 1997. Originally around the human mad cow disease outbreak. They do coordinate autopsy, neuropath exams, collect clinical information. They report to the CDC to track and investigate prion cases in the US. Originally, they're their only clinically available RT-QuIC test in the US. They're a very highly specialized lab. They started offering I'm not, give me a few plus or minus months here, but I believe they started offering this broadly clinically in 2015. And they would, at first, they were doing it on a reflex basis. And then more recently, I think 2019 onward, they perform it on all CSF samples that come in for evaluation. This is just showing their turnaround time, which this does not reflect, say, the last year. This is prior to the last year. They did a good job, but again, one of the goals for us was to try to improve the turnaround time a little bit. We at Mayo, we have a formal agreement with the National Prion Disease Surveillance Center to share public health reporting information so that we don't interfere with their mission. So all RT-QuIC positive cases, with a few exceptions based on state rules, we transfer that knowledge to the National Prion Disease so they can continue to track. And then our Mayo Clinic reports include reference to the services that they're provided, with the hopes that people will continue to use those services, some of which can be free for patients and families. I'm going to go through that. Again, RT-QuIC is very specialized. My understanding, current state within North America, There's the National Prion Center at Case Western Reserve. There's Mayo Clinic, and then there's the National Microbiology Laboratory in Canada that performs this testing. Its availability is I would say good in Western Europe and more spotty in Africa, South America, the Middle East, and Asia. So this is just high level, the Mayo Clinic turnaround time. Most of our cases were able to get out under 5 days, particularly negative cases. Positive cases, the majority were able to get out under 10 days, mainly because we repeat positives. Occasionally, we have a tricky case where we may repeat it 3 times. And then I'm going to 1 or 2 minutes, just real quickly. Biosafety risk for handling suspected CJD samples. So human to human prion transmission is exceptionally rare. It's almost all due to high-risk specimens, CNS tissue. There's not been any documented cases of transmission through CSF or any routine clinical lab handling, blood or CSF. There has been exposures due to surgical instruments. In the past, variant CJD could be variant form of the disease or coming from cows could be transmitted through blood transfusion. There's been no increased incidence of prion disease in healthcare workers at surveillance centers amongst pathologists, neurologists, lab staff. And contemporary animal studies show that brain tissue, but not CSF, can transmit disease in highly susceptible mouse strains. So we treat brain, spinal cord, ocular tissues, high infectivity. Blood and CSF is either considered low risk or no risk. There's a lot of questions come to handling. Basically, my lab handles CSF and blood using standard clinical lab BSL-2 techniques. With the thought is we're already handling samples that can potentially be carrying all sorts of infectious pathogens. And so if we're already handling those, the appropriate handling of those will also apply to those samples containing prion disease. And so we don't really do anything special. We educate our staff and make sure that everybody's transparent about our biosafety handling. I've gone a little long, so I'm going to wrap up. RT-QuIC, there's now applications beyond prion disease, so other neurodegenerative disorders, tau, alpha-synuclein, TDP-43. People have now demonstrated that these RT-QuIC could actually be used to detect seeding capacity in these other diseases. Currently on the market, there is the RT-QuIC alpha-synuclein assay. I believe clinically it's only available in one laboratory, Prion. It actually performs, research studies have shown it performs exceptionally well. In practice, maybe it's not achieving quite the same level of sensitivity and specificity as RT-QuIC for prion disease is, but it still provides a useful biomarker. And so in summary, generally the RT-QuIC assay at Mayo Clinic is very similar to that at the National Prion Disease. RT-QuIC offers superior sensitivity specificity, and that ordering these panels early in the diagnostic workup can help eliminate misdiagnoses. So here's my acknowledgments, and I have gone over, so I'm going to stop here and take questions. Thank you.
Thank you, Dr. Mills. Okay, we're now going to open our session for questions. Again, please submit your questions using the Zoom Q&A icon at the bottom of the screen. I will go ahead and pull those up. And while folks are taking a moment to type in any questions they may have, thank you, Dr. Mills, for addressing a couple of the pre-submitted questions that we got or that you received regarding the safety and the handling of these specimens. Is there anything additional that your laboratory does in terms of like the maintenance as well as the cleaning of the equipment that you utilize for these assays?
Yeah, so we don't do, so I have to preface that there's two parts to my lab. There's the part that does routine testing, and then we also do, where we perform RT-QuIC testing, we have some additional safety mechanisms, mainly because we're amplifying the product. There's the potential that we may get, an autopsy CSF sample, postmortem CSF sample, which carries more risk. In a standard clinical lab where we receive these samples, so when we receive them in the lab, we actually do our blood contamination assay in our main lab. We take no additional precautions related to CSF and blood handling than we would for any other sample that we receive in the lab. I think the important thing is that all samples have a risk of having a pathogen. That's why we use PPE, et cetera. CSF, again, is low to no risk, so we treat it no differently than any CSF that comes through our lab. And I would just, again, highlight that CSF has been sent to labs throughout the world, throughout our country for many, many years, and there has never been a documented transmission of any sort of clinical laboratory worker that is handling CSF or blood.
Thank you for that. You'd mentioned in your presentation that occasionally you get the sneaky serum sample that's submitted for testing in your lab for this particular assay. Are there any other specimen types that this test can be used on, or is that in the works potentially?
Yeah, so we only do CSF. There have been some more recent studies that have looked at olfactory bulb brushings. That there's some evidence that specimen type may be a little more sensitive. And then people have looked at tear fluid as well. Tear fluid, as far as I know, that is in the US at least, those are not clinically available. Tear fluid, the main drawback with tear fluid is that this is by interpretation of the data, but the specificity is not quite as good. And the sensitivity is not there. I can see certain situations where maybe it is not clinically feasible to collect a CSF sample, or if you need to repeat, where I potentially could see tear fluid being used, but I don't see it becoming a sample that would be recommended as a primary screening sample type because of some of the limitations.
How about biopsies for like postmortem cases, for instance, other than brain sample?
Yeah, we generally our lab does not accept tissue, mainly because when you're talking about any sort of CNS tissue or high risk tissues, there is a risk for handling those. And so we avoid that. Mainly those are tested and worked on in highly specialized Prion research laboratories that will often operate at BSL 2+, perhaps even BSL 3. And then obviously, anytime you're manipulating brain specimens, obviously, if you're doing a biopsy in a case of a patient with suspected prion disease, there's a whole different battery of safety precautions in terms of destroying surgical equipment. There's certainly risk when dealing directly with CNS tissues.
Thank you for that. All right, looks like we are right at the hour. So thank you all for attending today's webinar on real-time quaking-induced conversion assays from prion disease to emerging neurodegenerative diagnostics. Thanks again for joining us, and have a great day.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.